Welcome everyone. Good morning or afternoon, wherever you are. Welcome to the April edition of Pain Research Working Group. Today we have a presentation by Dr. Sarah Garrett and Dr. Francesca Nicosia, and they're going to speak about older adults' use of non-pharmacologic approaches for chronic pain, applying a person-focused model for research and clinical care. Dr. Garrett is a health policy fellow at the University of California, San Francisco. Philip Arley is a medical and cultural sociologist who studies how individuals navigate health challenges in healthcare institutions. She received her PhD from the University of California, Berkeley. Her work has spanned diverse clinical conditions, such as pregnancy, advanced cancer, dementia, and chronic pain, and has included methodological work to improve the conduct and communication of qualitative research. As a health policy fellow, Dr. Garrett currently researches the implementation and effects of interventions to reduce racial and ethnic disparity in domestic maternal health outcomes. Dr. Francesca Nicosia is a health services researcher at San Francisco VA Healthcare System and an assistant professor at the University of California, San Francisco Institute for Health and Aging. Dr. Nicosia is a medical anthropologist, certified yoga therapist, and health services researcher. She holds a master's degree in medical and biological anthropology from the University of Colorado, Denver, and a doctorate in medical anthropology from UCSF. She leads an integrated multi-site tele-yoga program funded by the VA Office of Rural Health and a feasibility trial of an integrated clinical yoga therapy program for midlife for women better, funded by the HSR&D Pain and Opioid Corps. She serves as yoga therapy and tele-whole health subject matter expert for the Office of Patient-Centered Care and Cultural Transformations Integrated Health Coordinating Center. So with that, I'd like to welcome Drs. Garrett and Nicosia and turn it over to them. Thank you so much for joining us today.
Thanks so much for inviting us. Sarah's controlling, or yeah, you're going to control the slides, so you can forward. Just our disclosure slide kind of it's going to give you the funding for this study, including NIA, ARC, and Office of Rural Health, and we have no conflicts of interest to disclose. Next slide. Yeah, so today I'm going to start with providing just a brief background on older adults in chronic pain. Obviously, this is the pain research work group, so kind of assume folks are pretty familiar with kind of basics around chronic pain, and then I'll talk more about non-pharmacologic approaches, both in the general population as well as among veterans. And then Dr. Garrett's going to share specifics of the study that we're presenting today, and I'll wrap up with some potential applications both for clinical care and research in the VA. Great, you can go ahead. So chronic pain tends to be more complex in older versus younger adults. And by older adult, I'm talking about 65 years and older. And between 60 to 70% of older adults describe pain in multiple sites, and over 60% of older adults also describe multiple types of pain. And we know that over half of veterans that are 65 and older experience chronic pain and related disability. Next slide. Great. So chronic pain in older adults can have complex effects on cognitive and physical function. So older adults with chronic pain are also at higher risk for falls, depression, substance use, sleep disorders, as well as decreased quality of life. And COVID-19 pandemic has exacerbated social isolation and sedentism, which really in turn contributes to decreased functioning and quality of life among those with chronic pain. Next slide. So pain treatment for older adults is pretty limited, as pharmacologic options Medications, including NSAIDs and opioids, have numerous physical, central nervous system, and cognitive side effects. And most pharmacologic options, are generally riskier for older adults because of age-related changes, for example, in renal function, drug-drug and drug-disease interactions, as well as increased rates of other adverse effects, including falls. And so in addition to these safety-related concerns, and some of my previous work on medication-related problems among older adults also highlights kind of the importance of considering or situating older adults' medication use within the social and emotional context of their lives. So kind of broadening out from just sort of physiological or other kinds of side effects. And so, of course, we know that the opioid epidemic in the United States has highlighted the need for non-pharmacologic pain management approaches, and clinicians and researchers are increasingly seeking alternatives to medication approaches for pain management, including with and among older adults. Next slide. Okay, so just thinking a little bit more broadly about trends in the use of non-pharmacologic approaches in the United States, the National Health and Interview Study in 2017 found the use of 3 complementary and integrative health, or CIH, approaches. Yoga, meditation, and chiropractic care were more likely to be used by adults under 65 years of age, those with higher socioeconomic status, women, and white adults, white identified adults. And so perhaps that's not surprising, but I just wanted to kind of give that background and specifically highlight the older adult piece. Slide. Right, and so while generally use of non-pharmacologic approaches, or CIH, which are not necessarily synonymous, as you'll see in some of our findings, but they're increasing among adults in the United States. But practitioner-based approaches are kind of among the more common ones that are used for musculoskeletal conditions. And we also know that mind, body, and movement therapies are used less often among people with multiple chronic conditions, including chronic pain. And so some of the known barriers include cost, especially for practitioner-delivered modalities, lack of availability, or lack of clinician recommendation. Right, so in response to the opioid crisis, legislation such as Comprehensive Addiction and Recovery Act requires VA to fund research on feasibility, safety, long-term efficacy, and implementation of non-pharmacologic and whole person or biopsychosocial approaches to manage chronic pain. And through this legislation and other mechanisms like HSR&D's State of the Art Conference on Non-Pharmacologic Approaches for Musculoskeletal Pain, and the Complementary Integrative Health Directive, VA has made substantial efforts to increase access to non-pharmacologic and CIH services, mandating provision of 8 modalities in addition to chiropractic care. Okay, next slide. Okay, so then among veterans and CIH use, recent studies have shown sort of increasing veteran interest and use of CIH approaches, with pain and stress reduction being among the top 2 reasons. And it's not surprising that pain is one of the 2 most frequently reported reasons for using CIH approaches, given the high prevalence of pain among veterans and efforts among VA providers to offer non-opioid alternatives for pain management. And veterans who use CIH approaches, such as massage therapy, chiropractic, mindfulness, and yoga, were in a national survey of over 3,000 veterans, found that these veterans were more likely to be under the age of 65, women, and have higher incomes than those who were not using CIH approaches, so kind of mirroring some of that earlier national general population data that I just mentioned earlier. Okay, and then, so one other thing, another interesting thing from a study by Stephanie Taylor and her group, so it was published in 2019, but the data I think was collected a bit earlier, is that veterans tend to be more likely to use some of these approaches outside than inside the VA, and we might see that shift over time, but I think we kind of don't quite know how that will land as increasing availability of some of these approaches happens. Perhaps that might shift. Okay. All right. So there's a knowledge gap though around older adults, right, specifically with non-pharmacologic approaches to manage chronic pain. And so we wanted to explore a little more deeply what factors influence older adults' decisions to consider, initiate, sustain, or stop using specific non-pharmacologic approaches for managing their chronic pain. And so with that, I'll turn it over to Dr. Garrett, who will share a bit more details about our study.
Thank you very much. And thank you again to the Pain Working Group for this invite. We're very happy to share this paper with you today. So Dr. Nicosia, just gave a really nice overview of broadly the topic we're looking into. I'm going to share the specific paper that we worked up and then hand it back to Dr. Nicosia to contextualize it in the context of the VA setting. So last year we published this paper, Barriers and Facilitators to Older Adults' Use of Non-Pharmacologic Approaches for Chronic Pain, a person-focused model. The study team initially was Drs. Chris Miaskowski and Dr. Christine Ritchie, who were the PIs. They engaged Nicole Thompson to conduct the in-depth interviews that are at the core of the project. And then Dr. Nicosia and I came on a little later to work on the analysis and the paper. So the objective of the paper, and there's a lot in the manuscript. I'm going to give you an overview here, and then we're happy to answer questions. But the objective was to characterize factors that hinder or support the use of non-pharmacologic approaches for pain management among older adults with chronic pain and multiple morbidities, trying to get at that knowledge gap that Dr. Nicosia referred to. We used qualitative methods for this work, and I'll talk about the methods across a couple of slides. We conducted one-time semi-structured interviews with English-speaking older adults, age 65 and older, with 3 or more self-reported chronic medical conditions who experienced persistent pain for 6 or more months. A study coordinator recruited candidates from senior centers, senior health fairs, and primary care clinics affiliated with a large academic medical center. All potential participants were screened for cognitive impairment, either by phone or in person, and individuals who did not pass the cognitive screen were excluded. And we used propositive sampling to ensure the inclusion of individuals of both low and high socioeconomic status. Interviews lasted approximately 45 to 120 minutes and took place at a location of the participants' choosing. They were all in person. We secured written consent and provided a $30 gift card for their time. The semi-structured interviews covered a lot of territory. A lot of it was about participants' chronic pain experience and medication use, but a big focus also was on use of non-pharmacological approaches. We focused on current and past experiences with non-pharmacologic modalities, how they came to use each approach, and we specifically focused on 10 common approaches drawn from the literature and pilot testing. So this was acupuncture, massage, chiropractic, physical therapy, mindfulness, breathing exercises, working with a psychologist or therapist, exercise yoga, Tai Chi, and ice. And then we also asked, using very open-ended questions about other non-medication approaches they were using to manage or had used to manage chronic pain. And so the interviewer came at this from a variety of angles, not only asking about how they came to use each approach, but their experiences of each approach, perceived effects on their chronic pain, as well as reasons for non-use of other approaches, including approaches that their clinician recommended, approaches that they themselves wanted to try, and approaches that they knew other adults used for pain. We considered for our analyses all non-pharmacologic approaches discussed by our participants, because this method allowed us to capture a broader range of what older adults are using to manage chronic pain beyond our pre-specified list. Analysis was, a very iterative and dynamic process, but to kind of describe it in broad strokes, During the first phase, we drew on the constant comparative method using analytic memos, iterative team discussions, and consideration of potentially disconfirming cases to develop a conceptual model of barriers and facilitators that influenced participants' use of non-pharmacologic approaches for chronic pain management. And then in the second phase of analysis, we developed a set of codes based on the components of the proposed model and applied these codes to all the interviewed data. And we did double coding on various subsets of the data to make sure that multiple members of the team agreed on the concepts we were using and operationalizing. This phase of the analysis enabled us to deductively evaluate and confirm the fit between the preliminary model we had developed and participants' experiences. And we conducted double coding in Atlas TI to ensure reliability and shared understanding. We also did some visual mapping to understand non-pharmacological use over time and use descriptive statistics to further describe these approaches in the sample, use of the approaches in the sample. So our sample, we ultimately had 25 older adults participate, which represented approximately half of the people we initially approached. And I'm happy to talk about reasons that people ultimately did not participate. They were 65 and older, and as they fulfilled all the criteria I set out before. 3 or more chronic conditions, chronic pain for 6 months or more. The sample was majority white and female, according to how they self-identified, and most reported having sufficient finances to meet their daily needs. Mean age was 72. And mean number of chronic conditions was 6. You know, taking that broad approach to how we were thinking about how we collected data on the range of non-pharmacologic approaches that participants used. And I will give you a visual in a minute of the range of these approaches. But taking all of them into account, we found that participants reported using a wide range of approaches to manage chronic pain. They used an average of 10 unique approaches over the course of their lives, ranging from 4 to 18 unique approaches ever used for chronic pain. And all participants were using at least one non-pharmacologic approach at the time of interview, the mean being about 5.5, 5 to 6, ranging from 1 to 12 approaches used at the time of interview. This table, I'll just briefly describe it. You know, this describes the 10 most common non-pharmacologic approaches ever used by participants in our sample. It's sorted from top to bottom in terms of the proportion of the sample who had used a given approach. So these are the top 10: acupuncture, physical therapy, ice or heat, exercise, massage, mindfulness. I'm not going to go through all of them. But we thought it was, after sort of being deep in our data, we thought it was really important to represent the contrast between approaches ever used and those that sort of persisted, those that people still used. These differences, you know, you see here acupuncture, 21, you know, the vast majority of the 25-person sample had used acupuncture at some point, but only 3 were using it at the time of interview. So these discoveries came out of mapping work that we did in the course of analyzing and exploring the data from our sample. And even though we asked about 10 particular approaches, you know, people described far more approaches. So we took several steps to kind of think about how to describe and represent the different types of approaches used. In general, we found that compared to what participants had used in the past, their current approaches were generally more self-directed and home-based. So just to give you an impression of this, and I know you cannot see really what's going on in this table, and I'm just going to talk you through it very briefly to give you an impression of it. But along the left-hand side, running in that first column top to bottom, are the 46 different unique non-pharmacologic approaches that we heard about from at least one participant in our sample. And then you'll see the rest of the columns running from left to right represent the 25 cases, the individuals in our sample. And light gray shading indicates that they ever used that particular approach identified in that row, and dark shading represents that they were using it at the time of interview. So I like to show this visual because it really does give a sense of how much work older adults with multiple morbidities and chronic pain in our sample were putting into exploring and trying different types of ways to manage their chronic pain using non-pharmacologic approaches. And it also gives you a sense of the kind of churn across modalities, across, within lives and across cases in terms of trying different things. We can come back to this, but I just think it's an interesting thing to see. Putting it up a little bit, putting up a subset, you can maybe see a little bit more that finding about acupuncture that most people had tried it, but only some were still using it is what you can see across that top row. So again, just an impression of sort of what this looks like in our sample. So, oh, and one other thing that I would just highlight, because some people are curious about the range of different types of approaches described. So you saw the 10 we asked about, the common ones, but other types of approaches used in our sample included breathing work, chanting and singing, cupping, dance, electrical stimulation, energy healing. Those are, just a sample of the types of approaches used. All right. So drawing on the qualitative data and the iterative analytic steps that we conducted, we found that participants, one, described a wide range of factors that hindered or supported their use of these approaches. And we categorize these barriers and facilitators into 3 broad domains: those that influenced their awareness of an approach as an option relevant to them, those that influenced the appeal of the approach, and those that influenced individuals' access to the approach. Ultimately, when we thought through and talked through all the different types of barriers, we identified that they fell into these 3 main domains. So ultimately, we proposed a 3A, the 3 A's model of barriers and facilitators, which integrates these person-focused domains. And we'll give you some examples of what this looks like in a moment. So here's the conceptual model, representing that the 3 types of domains here. And I'm just going to talk you through it briefly. So for example, awareness, starting at the bottom, captures that the patient does or does not consider the approach, the non-pharmacological approach, for themselves because they are or are not familiar with the approach, and they do or do not recognize its relevance to them or their pain. Looking at the access model, the patients, this domain represents that patients can or cannot use a non-pharmacologic approach because of issues related to cost or coverage, transportation, physical capacity, cognitive capacity, availability of approach, or other logistics. And then finally, appeal, which had many different kind of varieties within it in terms of how appeal was playing into things. This domain reflected that the patient wants to or did not want to use the approach based on whether they found it effective or ineffective, worthwhile or not worthwhile, comfortable versus uncomfortable or discomforting, enjoyable versus unpleasant or boring, satisfying versus unsatisfying, acceptable versus unacceptable, legitimate versus illegitimate or doubtful, and aligned or not aligned with sense of self. And there were other positive and negative feelings, but those were the main aspects we saw. So these domains together influenced whether participants considered, initiated, and continued using a non-pharmacologic approach to manage their chronic pain. Those who were using a non-pharmacologic approach had identified that approach as relevant to them and their chronic pain, wished to use it, and were able to use it logistically, financially, and according to their capacities. In contrast, for participants who are not using a particular non-pharmacologic approach for pain management, we observed that not all domains had been realized for them. So we think it's helpful to talk through some specific examples here to really flesh this out. So our first example is participant 23. this person greatly appreciated water-based physical therapy for pain management. She said it, quote, felt so good, and reported it as the most impactful non-medication approach she had tried. It was appealing to her in that regard. She wished to use it regularly, but Medicare covered only 6 to 8 sessions of it. For her, access was the barrier to her using this effective non-pharmacologic approach. And here on the slide, you can see also, she was aware of that modality because her provider had referred her to that water-based PT. A second example, participant 13 said she had, quote, loved yoga in the past and would like to do it again. That's the appeal factor. She had disposable income for exercise classes, so she had access to it in that way. But she believed that her knee injuries and pain now constrained her ability to do yoga. It turns out that she knew only about floor-based yoga. In this case, her lack of awareness about styles of yoga that could accommodate knee pain pain and knee injury was the main barrier to her using yoga as part of her pain management. And then finally, participant 6 had tried multiple sessions of acupuncture after her clinician recommended it. So she had the awareness piece. Her HMO covered her acupuncture sessions and they were conveniently located, so she had access to them. But she strongly disliked it. She said it, quote, hurt so bad, and she, quote, didn't trust it or believe it. She also felt it didn't relieve her pain. She decided never to return. So for her, appeal is the key barrier. I'm now going to turn it back to Dr. Nicosia, who's going to discuss potential applications for our paper's findings and the 3A model for the VA setting.
Great, thanks so much. So in the article, we really, and kind of what Dr. Garrett just went through some of the findings, we wanted to provide suggestions for how clinicians might use these 3A domains to guide conversations and decision-making with patients around their use of non-pharmacologic approaches, both for practitioner-led and self-management strategies. So you can click to the next slide. Right, so on the left, you can see the domains of awareness, appeal, and access, and then we listed out some sample or example corresponding questions for each. So, for example, for awareness, asking patients, do you know that X, Y, or Z is something that may be able to help you with your pain, and then following up with more information or education or even a demonstration, depending on what the approach might be, on what it is and how it might be helpful. Similarly for appeal, just inquiring about patient willingness to try something. So, asking if they'd be willing to try. And then for access, considering factors that might make it difficult to initiate or continue using a given approach. And so also just keeping in mind too, from what our data illustrated, that older adults really are willing and open to try multiple strategies, as well as having varied reasons for not using a particular approach. So these questions can and should be revisited over time. And so today, maybe you can click to the next slide. I also wanted to think through just some potential applications of this model in the VA, including sort of clinician level as well as health system factors. So you can advance. So you can see here's the little triangle again. And so thinking about awareness at the level of clinicians, right? So this can just include a general awareness, of a particular approach, either, just from daily life, popular culture, news, media, or, and then, or perhaps it's available, right, in your facility, as well as personal experience, right? So do you have, personal experience using that particular approach, right? Perhaps for your own chronic pain, right? Or for some other reason that you can speak to it in that way or not. And then clinical knowledge and practice. So, either being trained in a particular modality, having learned about it, or actually using it in practice and being able to offer that to your patients as a provider a provider-led modality. All right, and then next slide. Okay. And so then appeal for, at the clinician level obviously has some overlaps with awareness, such as personal experience, but really kind of also speaks to underlying issues around sort of attitudes or beliefs about a particular approach or modality, as well as interpretation of the evidence base, because we know that some approaches have a stronger evidence base than others. And then bias or assumption about the appropriateness or feasibility for older patients or for older veterans. And then finally, sort of personal comfort level with providing or counseling and providing information to patients about various approaches, and just again, remembering that offering a variety of options is important given factors related to patient appeal. Okay, and then for access, I'm kind of just thinking about this in terms of health system access. And so this really requires availability, right, at the facility. And then, some kind of known factors that impact implementation of CIH and non-pharma approaches in VAs. There's been, a lot of research done by Stephanie Taylor and Barbara Bocor's groups, identifying leadership support, processes for credentialing or hiring CIH professionals, integrating them into care teams, provider ability to provide that patient education we talked about in the appeal domain, as well as having clear referral processes, and sort of availability of appropriate delivery methods, such as in person, through telehealth, or self-management. And so, right, these largely mirror known barriers to implementing CIH modalities in the VA. And, and as access really is a key factor, it's important to highlight, especially when considering the needs and preferences of older veterans. So for example, I'm a yoga therapist and teach yoga to veterans. And so I'll just speak to yoga, for example, because it's widely available in a lot of VA facilities. And so although it might be offered right at your facility, perhaps the style is not necessarily appropriate for older adults that have multiple chronic conditions if the instructor or the clinician who's certified, right, doesn't necessarily have background or skills to adapt or modify the practice for older adults with chronic pain, musculoskeletal issues, multiple health conditions, and potentially cognitive concerns and limited mobility, right? So as these are not really typically included in a general or introductory yoga teacher training program. So it's kind of some of the nuance to think about appropriateness in access. Okay, next slide. So in terms of future directions for research, so we know there's really a demonstrated need for a deeper understanding of older veterans' use of non-pharmacologic and complementary, I'll just say CIH approaches to manage chronic pain, right, which may be co-occurring with other conditions, both, right, so that's one. And then also kind of related to that is, leveraging VA data around usage and using 3As, awareness, appeal, and access to frame qualitative research questions, really to get at the why and how, which are things that kind of, big data sets can't necessarily answer. There's also potential to assess the feasibility of this 3A model as a communication tool, as well as future larger studies kind of testing the impact of that on related outcomes. We're also curious to hear about other ideas that might be sparked by this talk. So we can discuss that, in our Q&A, or, reach out to us later. Next slide. So yeah, just to highlight the key takeaways about the model that we've presented, is these 3As kind of represent patient level experience, right, of barriers of facilitators to using non-pharmacologic, a wide variety of non-pharmacologic approaches for chronic pain management. There's some applications for both clinical and research use, and specifically guiding clinician communication with older adults about their use of non-pharma approaches to managing their chronic pain. Yeah, this is our contact information. I think we have plenty of time to open it up for questions or discussions. So we'll be happy to have some dialogue with folks that are on the call about this if you have specific questions, comments.
Thanks so much. That was really very interesting, and I think something that is so important for all of us to be thinking about implementation and increasing uptake of these interventions, these non-drug interventions. So I'm going to open the floor for questions. Folks can either type their questions in the chat box or go ahead and propose one. I'll be quiet for a second, so if anyone wants to speak up with a question. Oh, Alex?
Hey there, can you hear me?
Yes.
Yeah.
Great. Yeah, hi, my name's Alec. I'm actually a chiropractor over here at the VA Palo Alto, and I also do acupuncture. Great presentation, really interesting to hear this. I'm just wondering if you guys have any suggestions in what you found or just personal experience. Is there anything we can do as providers who are offering these services to help primary care or other pain management services for awareness or education on what we actually have to offer? 'Cause sometimes I find when I see a patient that's, I didn't even know we had chiropractors here, and we've been here since 2015 now. And again, I don't know that's fault on anyone, but other than knocking on every primary care's door, how do we help promote and let people know what options there actually are for myself and otherwise, pool therapy, rec therapy?
Yeah, great question, Alec. I mean, I don't know if I have all the answers to your question, but I mean, it is Whole Health Week. And so, I think a lot of facilities are kind of organizing, a lot of promotional kinds of things that are both veteran facing as well as employee facing. So I think that's kind of one way to get the word out. I think this is like one of the $1 million questions just in thinking about implementation of these kinds of modalities. I know that, in our integrative health service at the San Francisco VA, we do work really closely with both mental health and primary care, just to provide a lot of education and communication just about our offerings that are available. And so I think, some of the findings from some earlier research studies really, highlight that like one facilitator is having a centralized pathway or centralized way for a lot of CIH modalities to be accessed. So I don't know, I'm curious, I'd love to hear, I know there's a lot of other, I see some names, there's some folks here too that might also have some input about that. But yeah, I think a lot of so I think there's like institutional level things that can be done, leadership support, right? And there's, just personal relationships actually, I think with other providers and clinicians, can probably go a long way too. So those are my thoughts. Sally.
So I have a question, I guess along similar lines. So I like your 3A model as a way of thinking about things, and it seems like a lot of what VA has done has been try to rightly, I think, address the access A. And as you've been saying, I think awareness and appeal are huge components. I'm wondering if either of you from this work or other work think that there is any particular messaging that you think might be helpful in thinking about, I hear suggestions, and I think it's probably a good idea of, informational campaigns or messaging campaigns could be helpful. Thoughts about components of that, or even specific tailoring that you think might be helpful for older adults?
Yeah, I mean, great question. I think we know that like veterans like to have like written material, right? I think, and as well as providers, so just like handouts that kind of describe something, and like one-page sheets for kind of different modalities can be helpful for providers, like, because I mean, as you saw, right, and like that visual, you know, that we had. It's like 43 different approaches, right? That the folks in our studies had identified that they have been using or trying, and so, you know, kind of thinking about like the mandated modalities, like the 8 or 9 modalities that are mandated, you know, for VA. So it's a much smaller number, but you know, Office of Patient-Centered Care does, you know, has materials on their integrative health or integrative health coordinating center SharePoint that kind of describes a little bit more detail about those. So it's like, I think, you know, for a lot of clinicians that might not necessarily be integrative health providers or practitioners, or perhaps in one modality, but not, you know, all of the other potential ones, I think that it's a challenge, right? To be able to provide like clear education or information to patients on all of them and all of the benefits and all of the evidence base. I mean, it's a tall order, I think. And so having like a centralized place where patients can go, like we have in San Francisco, we have an online like whole health resource directory, right, where patients can go and look at different options, both that are offered within the VA as well as outside in community referrals or in community options that provide free or low cost access to veterans. So that's one model. But I think the tailoring, this is a really great question. I mean, the tailoring piece for older adults specifically, I mean, I think in any kind of written material, like just really simply larger print and like simplified reading level can be really helpful. It's kind of just some general basic rules of thumbs for older adults, written materials. Yeah, I think, I don't know if other folks have suggestions or thoughts on your personal experience working with older veterans on that.
Well, I'd be happy to share just a little more from our data that I feel is relevant to this question. I mean, I think it's an interesting point about that and I want to be transparent. I'm not based at the VA. I'm not a pain scholar. I'm really on this project as a qualitative methodologist, and my work has mostly been unrelated to pain. But so I think it's interesting, you know, the point about the VA has done a lot of work around access, but maybe there's work to do around the access and appeal points. Based on the things that respondents in our study were saying, it just seems like even for people who have tried a lot of different things and who have been trying to manage their pain for a long time, a lot of them remained hungry to hear about more options. You know, there is, I think, a great appetite for learning about, you know, other ways to manage one's pain. So, you know, I think about like work I've done in oncology settings where it seems like a lot of patients really appreciate getting a sense of the landscape of options that will be available to them, you know, whether it's for treatment or for pain management or for sort of complementary treatments or supports going on. But just giving people a sort of holistic sense of what they might consider as they navigate managing their pain. That seems empowering for people. Because yeah, in our sample, I mean, there were multiple participants who, after being asked about the 10 modalities, the 10 different approaches that were named in our interview guide, some of them were taking notes saying, you know, do you think this is relevant for my pain? I think I want to try this out. They were learning about approaches from the interview. So I think there remains a great interest even among people who have developed great expertise in managing their pain and trying new things. And yeah, I'd love to hear more from others about your thoughts on this.
Yeah, another thing too that just kind of came to mind as well is like, you know, I think, at least in my experience in working with older veterans, in the context of yoga and therapeutic yoga, is that, you know, offering modality or offering things within the VA as part of VA care that can be integrated in people's care plan. And I think, you know, there is, right, I think there's a lot of interest in, you know, assessing access and outcomes related to community care, right, which can definitely be appropriate for certain things. But I think for older veterans or for older adults or older veterans in particular, I think like you saw in one of the examples that we showed around acupuncture, or I can't remember, yeah, is that it was integrated within her, it was in the same setting, right? That she could go to it. It was co-located with her other medical care. And so I just think that is quite appealing, right, to people. It's much more convenient, less travel burden, and it's, you know, less of a headache to try to get a referral and find people or find someone that will, you know, take a community care referral for older veterans in particular. And then just another thought just around like the access, or sorry, the awareness issue, or how to raise awareness. You know, I think as clinicians or people that are interested or supportive of whole health or non-pharma, you know, CIH modalities, you know, figuring out like who is a whole health point of contact at your facility. Is there a steering committee that you could join? Like what like are the opportunities to just raise awareness within specific clinical services or facilities? So.
Going back to that point you just raised about the appeal of having treatment kind of folded into the clinic. So I work primarily in addictions, and veterans with opioid use disorder that are engaged in some sort of medication for OUD, and then finding ways to get engaged in pain care, I think, is challenging. I think it addresses the first awareness. A lot of clinicians who are providing that care might not be aware of all the resources for pain, but even with the referral process potentially being rife with stigma or concerns about going to another clinic or talking about pain when they are on MOUD. I think a lot of the issues you're raising with older adults see completely with, you know, veterans who have addiction that are coming in for treatment and continue to have really high rates of chronic pain. This is really helpful just to even think about how we can better serve those populations that still have a lot of resources available to them, but accessing those resources and also folding them into the clinic to make it more appealing or more accessible, as opposed to referring to community or other clinics within the VA hospital.
Yeah, thanks for that point. And yeah, I don't think this is necessarily limited just to older adults or older veterans, but I think there are, you know, particular, you know, concerns that make them a bit of a unique population when it comes to these things. But yeah, that's kind of good to hear that it's sparking thoughts for you, kind of within the setting where you're working.
Yeah, and to agree with that, the advantages of like co-locating and making things more convenient, I think, can't be overstated. I mean, some of the saddest examples in the sample to me in our data were around participants who were so interested in accessing a particular approach or trying a new one or continuing with one, but that the logistical barriers to getting there just were insurmountable for them. And it might not have been insurmountable for someone who maybe didn't have chronic pain or didn't have multimorbidities, who was more energetic, who had like access to a car. But there's a lot of will there, but logistical barriers, access barriers that are pretty hard to get around. So yeah, improving access, even if the VA is already doing a good job, I think it's sort of limitless how much it could be improved.
Yeah, I also too think like, you know, that there's also like room for clinicians to sort of investigate or think through with their patients about, you know, like things they might be doing outside VA care, like that aren't one of those 8 modalities or like that have a high evidence base. Because as you saw, like the folks in our study like used such a wide variety of things that perhaps might not traditionally or typically be thought of as like a pain management modality, right? So, you know, and I know, like we know, like from research that people tend not to disclose use of supplements or herbal remedies or things like that necessarily to their healthcare providers, and so kind of just broadening the idea or like the concept of what is self-management or pain management thing that people might be doing I know there's even studies that are ongoing around the efficacy of prayer, right, for chronic pain, right? So just kind of thinking about kind of broadening the scope of what we think about. And it's tricky in a healthcare system because, right, there is the need to have like, you know, an evidence base for modalities that are being supported, but just, yeah, just kind of being a little bit more broad in our thinking about what we talk about with patients or what we invite them to talk about without kind of being fear of being judged.
What has really struck me was that, you know, the number of things that people have tried, that was really quite striking. And, you know, the comment about people really want to know what's available. And I think sometimes we forget those kind of simple interventions, like you were saying, you know, written materials, kind of describing what's available and what these different modalities are, or a single point where, you know, in the whole health model where someone could sit with a coach and really walk through the options, seem to be, you know, really very promising because our current model is often, you know, a primary care provider, one provider educating their patients in what is often a very limited window of time in a visit, especially for older patients who often have more comorbidities. It's highly inefficient, and it depends on if your provider is knowledgeable, which not all providers have the time or the inclination to be knowledgeable about those things. So, you know, that kind of information, having that information available, I think is really important. And it may also start to address some of this, what the other thing I heard you talking about is stigma, right? So as a psychologist, you know, we're aware that patients often particularly feel a sense of stigma about psychological interventions. And so thinking about how to increase awareness and reduce that stigma. We had a recent veteran engagement panel through the Pain and Opioid Core, and we were talking to them about psychological interventions. And something that stuck with me that someone said was, I've heard of this, but not from my provider, and I'd love to. And, you know, there should be more talk of psychological interventions and other interventions. Say it until everyone knows it and everyone thinks it's normal, right? And I think that's, you know, that's another thing that people need to have that normalized and not just the medical, you know, the drugs, the procedure side of it.
Yeah.
See if anyone has any other comments or questions.
I was I'll put here in the chat the link to our San Francisco VA's kind of whole health resource, online resource guide, just in case folks are interested in kind of seeing one model of what that might look like. And it covers the whole, you know, our whole healthcare system, including CBOX, as well as some community resources. So you can, if that's something that you're interested in, get the links there.
Yeah. Always helpful to have some examples. So thank you everyone for joining us. Thank you, Dr. Garrett and Nicosia. I appreciate your time and your work and hearing about it. And everyone have a good rest of your day. Thank you. Bye.
Thanks so much.
Yeah.